Hi, my name is Nicole Vargas and I'm talking about randomized trial of endoscopic or open vein graft harvesting for coronary arteries bypass. Definition. It is a surgery that creates a new route, called a bypass, so that blood and oxygen can avoid or blockade and reach the heart, with the possibility to undergo two procedures. One is by grafting the saphenous vein, and the other is cardiac revascularization by stopping the heart and with a machine supplement to sustain this leg. Pros and cons. Open OVH, well established. 2. Long incision. 3. Delayed ambulation. And 4. Increased hospital LOS. Endoscopy, EVH. 1. Decreased wound complication. 2. Patient satisfaction cosmetic learning curve. 4. Concern for increased graft occlusion, internal injury. And 5. Unknown long-term outcomes.
Hello, my name is Faisal Bakian. I'm a staff cardiovascular surgeon at the Department of Thoracic and Cardiovascular Surgery at the Cleveland Clinic. Today we're going to talk about the results of the REGROUP trial. It was just presented at the American Heart Association, and simultaneously the manuscript was published in the New England Journal of Medicine. This study randomized patients undergoing coronary artery bypass grafting or CABG into veins harvested either endoscopically, meaning with the help of an endoscope and small keyhole incisions to harvest the veins from the leg, versus the traditional open approach, which typically involves skin incisions separated by bridges and sometimes, out of necessity, a long skin incision. And the impetus of the study was really the question that was lingering in the cardiovascular community about the safety and efficacy of using less invasive means of taking the vein, which continues to this day to be the most common conduit used to supplement the left internal mammary artery bypass to the left anterior descending artery. And there was a question of whether using a minimally invasive technique with an endoscope would harm the vein and result in bad outcomes. And it really dates back to a study in 2009 published in the New England Journal of Medicine, which was a post-hoc analysis of the PREVENT-4 trial. It was designed to answer something else. But in fact, the post-hoc analysis showed worse clinical outcomes in patients receiving endoscopically harvested veins. So this raised alarms in the cardiovascular community about whether we should be using the endoscopic minimally invasive technique or whether we should revert to the open skin incisions. The problem with the open skin incisions is that they're cosmetically less appealing, obviously, because we make big skin incisions, but also there's a higher incidence of wound infections and wound complications related to those bigger incisions, and the compromise was to do smaller skin incisions separated by bridges. So the REGROUP trial is the largest multi-center prospective randomized trial on this subject that we were a part of, and in fact I'm a member of the steering committee. We randomized 1,150 patients to either receive an endoscopically harvested vein or a vein harvested through skin incisions, and we tried to minimize those skin incisions, as I said, and separate them with skin bridges. The median follow-up of the patients was under 3 years, and the primary outcome measure was the major adverse cardiovascular events. Now, the study results were negative, meaning that patients who received veins using the endoscopic technique had similar outcomes to patients who received veins harvested through traditional means. In other words, there is safety to the method of using minimally invasive endoscopic harvesting. So that was a big sigh of relief for the cardiovascular community. And as expected, actually, there was less incidence of wound complications and leg wound infections in the group of patients that received endoscopic harvest. So there was incidence of just over 1% of leg wound in complications and infection in patients who underwent endoscopic harvest versus over 3% in patients receiving open traditional harvesting technique. Now, one point, actually 2 points that I want to raise here is first, the study emphasized the importance of the experience of the harvester, meaning that you can't be a novice endoscopic harvester to harvest veins for patients enrolled in the study. So you had to be a competent endoscopic harvester and a competent open harvester. So those results are representative of this kind of medical team taking care of you, experienced medical care team. Another point I want to raise is, at the Cleveland Clinic, we've always thought that using more arterial grafts can be beneficial in select group of patients, and we have demonstrated that using bilateral internal thoracic arteries and multiple arterial grafts, such as the radial arteries, can be of benefit to patients, specifically in terms of prolonging patient survival. And the benefit usually kicks in many years after the procedure. So we're not just interested in immediate outcomes, we're interested in long-term outcomes and for our patients to have a durable operation with excellent quality of life. So our approach at the clinic is to use arterial grafts to supplement the left internal mammary artery to the LAD whenever possible to enhance the longevity of the patients. And in patients who would require saphenous vein supplements, we use minimally invasive techniques such as endoscopic saphenous vein harvest, and we have excellent outcomes using that technique. And this study really validated our approach. Thank you for your attention.
Methods. We randomly assigned patient undergone CABG at 16 Veterans Affairs cardiac surgeons centers to either open or endoscopic vein graft harvesting. The primary outcome was a composite of major adverse cardiac events, including death from any cause not fatal, myocardial infarction, and repeat revascularization leg wound complication were also evaluated.
We have Dr. Stephen Prince, head of the Division of Cardiac and Vascular Surgery at the Schulich Heart Center, Center for Health Science Center in Toronto, discussing the study of radial artery and saphenous vein patency more than 5 years following coronary bypass surgery. Results from the randomized multi-center radial artery patency study called RAPS.
This is a late analysis of our earlier study. We initially enrolled 561 patients from 13 centers to report one-year patency studies at 2004. Study design was patients with triple vessel disease had their radial artery randomized to the right circumflex territory, and saphenous vein graft randomized to the opposite territory. The randomization was between study territories within the patient as opposed to between patients. At 1 year, the radial artery had better patency, better overall patency, the so-called FERT perfect pace, it was similar. So at 7.5 years, the primary endpoint was perfect patency or conversely functional graft occlusion, which was reduced in radial arteries. It was approximately 19% graft occlusion rate in saphenous veins versus 12% for radial. One of the secondary graft occlusion endpoints was complete graft occlusion, which was approximately 18% versus 9%, odds ratio of 0.5.
Result: post-op pain, lower pain score with AVH P equal 0.001. Effect size depends on system usage. Wound infection lower in AVPMH. All-cause wall CX lower in AVH. And post-op in myocardial infarction, no significant difference. 30 days mortality, no difference in randomized data. Vein graft stenosis, only 2 studies ballet. Vein graft occlusion, no difference in randomized data. Angina recurrence, no significant difference, and repeat revascularization, no significant difference. Mid-term myocardial infarction and mid-term mortality, no significant difference. And OVH, AVH, harvest time, AVH 53 minutes, and OVH 34 minutes. AVH and OVH 30 days, 1 complication and pain score. AVH more OVH, cosmetic AVH more OVH, and 9 AVH converted to OVH, and small veins, varicose states, and branch avulsion, cellulitis, and one night, and LOS equivalent.
I had the privilege of presenting the results of the regroup trial today at the American Heart Association. This is a large randomized trial funded by the Cooperative Studies Program of the VA in 16 centers. We randomized 1,150 patients needing coronary bypass surgery to either endoscopic or open vein harvest. The scientific premise for the study was a safety signal that was reported in 2009 by investigators at the Duke Clinical Research Institute, demonstrating a near doubling of the mortality at 18 months in patients receiving endoscopic harvest. And those investigators appropriately recommended a prospective randomized study. And that call was answered by the Cooperative Studies Program of the VA, which is one of the oldest and most respected trial networks in the country. And we presented today the results of the active follow-up phase, lasting about over 2.5 years. And in this study, we demonstrated that patients receiving endoscopic vein harvest had similar outcomes to patients receiving open harvest when the procedure was done by an expert. So those results also confirm that endoscopic harvest results in better wound healing, less pain, and more comfort for the patient. So in conclusion, we believe that when performed by an expert, endoscopic harvest is the preferred modality for conduit procurement for patients requiring CABG.
And conclusion. Based on the current evidence, ABH is superior to OBH for short-term patient satisfaction, cosmetic and wound complication. Though there may be an increased rate of graft occlusion and ABH, long-term occlusion and mortality rate are only hypotheses and generally at this time standardized prepared protocol, exercise, smoking cessation and meds.
Showed no difference in outcomes in terms of major adverse cardiovascular events in patients who had saphenous vein graft harvested endoscopically versus open in a randomized trial. It also showed that there was reduced risk of wound complications in the patients that had endoscopic harvesting. I think this trial opens the question for further investigation, a larger study, more patients of diverse not only gender, as this study was largely male, but also a larger group of patients with multiple comorbidities. Who may have had multi-vessel disease. So I think it opens the question for further study. Any longer-term follow-up we could have would be beneficial. In addition, data on patency would also be very helpful. The use of one arterial conduit is now a quality measure and is mandated. And that data is publicly reported for surgeons. So we know that the use of the left internal mammary artery to left anterior descending should be done in all patients, if possible, undergoing coronary artery bypass grafting. And there are a lot of data now that suggests arterial grafting is beneficial to survival and for patency over the long term. So the longer term data that we would have, the more information we would know. However, vein grafts will always be in our armamentarium if arterial grafts are insufficient or inadequate, or for example, do not provide adequate flow in an emergency situation. So we will always want to know, would it be better to harvest it open or endoscopic or with small bridging incisions? Different surgeons are driven by different motivational factors. Time is one of them, whether or not they believe the data, the literature, and that arterial grafting provides prolonged survival and better patency compared to vein grafting. Also, many of us work at teaching institutions, and doing all arterial grafting takes a little bit more time and is technically a little bit more challenging and may be more difficult to teach in contrast to a vein graft.
And thank you.